Welcome to our NHS West Yorkshire board meeting. We're here in Leeds today. Hello, my name's Cathy Elliott and I am Chair of NHS West Yorkshire Integrated Care Board, ICB, and I'm also Deputy Chair of our Health and Care Partnership. All the board documentation for this meeting today in Leeds is available online, and you can follow the agenda and also the discussions taking place. And there's a whole variety of things we'll be looking at today. We have our Reducing Inequalities Focus On session, where we'll be looking at ageing well in West Yorkshire, as well as more standard reporting, where we'll be looking at system performance and also our winter planning and delivery. So I'm going to start at this side of the table over here so people can introduce themselves, and it's helpful for people in the room and watching online to know who we've got around the table representing the Health and Care Partnership as well as our board members. Muz, would you start us off, please? Thank you.
Sure. Hi everybody, I'm Muz Mumtaz and I'm on the Insight programme as an observer.
Hello everyone, my name is Fatima Khan Shah. I am the West Yorkshire Inclusivity Champion, which is a shared role between the Health and Care ICB and also the West Yorkshire Combined Authority advising on equity and social justice.
Good afternoon, I'm Jane Madeley. I'm a non-exec member of the board and the chair of the audit committee.
Hi, I'm Tim Riley and I'm the place lead for Leeds for the ICB.
I'm Rachel Loftus from local government, deputising for Mariana Pexton for about the next hour or so.
Hello everyone, I'm Melanie Brown, place lead for Wakefield District.
Hello everyone, my name is Shaukat Ali Khan. I'm the Chief Digital and Information Officer for the West Yorkshire ICB.
Hello everybody, I'm Kim Shuttler. I'm the lead for the Voluntary Community and Social Enterprise sector for the ICB.
Hello, I'm Robin Taddenham. I'm the place lead for Calderdale and the Chief Executive of Calderdale Council.
Good afternoon, I'm Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Hello everybody, I'm Brendan Brown. I'm the Chief Executive at Calderdale and Huddersfield NHS Foundation Trust, and I'm here as the Acute Hospital Sector Rep, and I'm also representing Karen Jackson today as the Community Rep.
Hi everyone, I'm Hannah Davis. I'm Chief Exec at Health Watch Leeds, and I'm here on behalf of the 6 local Health Watch working across West Yorkshire.
Hi everyone, I'm Majid Hussain, one of the non-exec members of the board.
Hi, Amy Willett, Head of Corporate Governance for West Yorkshire ICB.
Hello, Laura Ellis, Director of Corporate Affairs.
Hello, my name is Rob Webster. I'm the Chief Executive.
Good afternoon, I'm Jonathan Webb, Director of Finance and Deputy Chief Executive.
Hello, my name's Ian Holmes. I'm Director of Strategy and Partnerships and Deputy Chief Executive.
Afternoon, I'm Ranshu Chatterjee, non-exec member for the board and chair for the Finance, Investment and Transformation Committees.
Good afternoon, I'm Lou Auger. I'm the Interim Director for Planning and Performance for the ICB.
Hello, I'm Richard Vautry. I'm a GP in Leeds and the Primary Medical Services member.
Hello everyone, I'm Victoria Eaton. I'm a partner board member on behalf of all 5 directors of public health across West Yorkshire.
Good afternoon, my name's James Thomas. I'm the medical director for the West Yorkshire Integrated Care Board.
Hello, I'm Carol McKenna and I'm the place lead for Kirklees.
Hello, I'm Nadal Mirza, non-executive member of the ICB and also chair of the Quality Committee.
Hello, my name's Sarah Munro. I'm Chief Exec of Leeds and York Partnership Trust and Sector Lead for Mental Health, Learning Disability and Autism.
Afternoon, I'm Anthony Keeley. Excuse me. I'm the outgoing ICB Director of Planning and Performance and the Accountable Emergency Officer.
Hello, I'm Kate Sims. I'm the Director of People at the ICB.
Therese Patton, Chief Exec, Bradford District Care Trust and Place Lead for Bradford District and Craven Place.
Hello, my name's Sarah Smith. I'm Deputy Director for the Improving Population Health function at West Yorkshire ICB and here for the Health Inequalities item today.
Hello, I'm Colvin Sandhu, Senior Programme Manager at West Yorkshire ICB, and I oversee our programmes Unpaid Carers, Personalisation and Palliative End-of-Life Care, also here for the Health Inequalities piece.
Hello there, my name is Sarah Chadwick. I'm Antimicrobial Resistance and Infection Prevention Programme Manager at West Yorkshire Integrated Care Board.
Thank you, colleagues. If I just ask just to check that you've turned all your microphones off That's great, and then we'll move on. So, as I said, welcome to our December NHS West Yorkshire Integrated Care Board meeting. We have the breadth and depth of health and care here. We have our board members who are voting board members, and then we also have colleagues who are here to observe and contribute and present today. And thank you to Sarah and Colvant for joining us today for our Focus On session, which we'll come to shortly. First of all, I wanted to welcome some new people. Shaukat, you've just introduced yourself. Welcome as our new Chief Digital Information Officer, a new role for our health and care system. And also to Nadra Mirza, who is our new non-exec member, particularly chairing our Quality Committee and having a system remit for maternity safety. So thank you. Warm welcome to you today. Thank you for joining us for your first board meeting. The next item is around declarations of interest. Does anyone have any declarations of interest in relation to today's agenda? Looking around the table. No? Okay, and I wasn't made aware of anything in advance. Colleagues around the table, as you know, we have an online portal of live declarations on mydeclarations.co.uk, and this is also a way for staff working in health and care and also for members of the public to see our live declarations of interest as well. And that's available on our website. So we then move to item 12, which are our minutes of the previous two board meetings. So if you remember, we were together in September in Huddersfield for a full meeting that day, and we had a Focus On session, which we may reflect on in a moment. And also we had an extraordinary board meeting on the 11th of November to look at specialist commissioning, which was via MS Teams. And that was available on live broadcast as well for members of the public to view. So, colleagues, do we feel that is an accurate record of the board meetings? First of all, on the 24th of September. Yeah, okay. And then on the 11th of November. Yeah, okay. I'm taking silence as agreement, which is fantastic. And then, should we go then to the action log, first of all, for the 24th of September? So, Laura, to you.
Thank you. Yes, if I can direct you to, if you're using the full pack of papers, it's page 347 for our action log. The first action is not yet due, that's in respect to the digital strategy. The second action, which is open, relates to Home Office policy relating to people seeking asylum, and I'm going to pass to Robin Tuddenham, if I can, please, to respond to that.
Yeah, thanks, Laura. Just to advise the board that I have briefed all Yorkshire and Humber Chief Executives. It's an issue that we discuss at the Yorkshire and Humber Chief Executives meeting. I can advise that the situation remains very complex and challenging in relation to people seeking asylum, but that local government is working in a way with the Home Office that's more collaborative and more co-produced than before. We have a workshop in the new year about future models of asylum dispersal, and I'm currently interim chair of the national group with the LGA and the Home Office and MHCLG. So we are able to influence more than in the past. We also have excellent support around migrant health from Cathy Railton at OHID and Anna Hartley, who's the Director of Public Health or Director of Communities at Barnsley, and our lead for the region. So we have a level of influence and engagement that's strong, but I will say that the issues of the demand and the challenges with dispersing to good quality accommodation remain very, very challenging. But I can say this is closed.
Thank you, Robin. And for anyone who's been interested in our work as a board and discussions, you can see that this has been something we've talked over for many months. So thank you very much for that update and representing the system. Is there anything else on the action log to note? From the 11th of November, anything? No. Okay, so thank you, colleagues. And if you're interested in an update on specialist commissioning, there is something in the Chief Exec's report in item 17, which links back to our 11th of November virtual meeting. So the next section of our board is public questions. As you know, we always invite public questions to our ACB board meetings, the same way as we invite questions to our Integrated Care Partnership board meetings every quarter. And thank you to two people who have shared questions with us today. And I'm going to hand over to Laura. We've got one from Heather Tattersall and one from Dr. John Pontus. So Laura, to you.
Thank you. I'm going to take Heather's question first. I'll read out the question, then I'm going to pass to Sarah Munro in order to respond. So the question is, I have worked in mental health for almost 20 years, and for the first time in my career, I have this year been summoned to attend coroner's court in West Yorkshire following a suicide. The Mail had been under secondary mental health care, but given caseloads over capacity and revolving staffing due to the increased pressures mental health staff and services face, he had not been given the care he needed. Given the news about proposed removal of the mental health investment standard, what assurances can you give that you will make sure that West Yorkshire Integrated Care Board does not decrease mental health funding even further, which will result in more death by suicide? I'll pass to Sarah, thank you.
Thank you, and thank you, Heather, for the question. And for your support of mental health services, and just to acknowledge how sorry we were to read of your own recent experiences. The far-reaching consequences when you lose somebody to suicide is not to be underestimated, and then the experience of having to attend an inquest after that is obviously adds to that distress. Just to acknowledge, mental health services are in very high demand. We are grateful for all the work our colleagues do day in, day out across all of the different sectors supporting mental health, providing that much needed support and treatment. But unfortunately, as with the whole of the NHS services, demand currently outstrips the resources we have to meet the need, and we know that in turn creates pressure for our frontline teams. We are still awaiting the planning guidance, and we expect and hope it makes explicit asks of all systems to continue to invest in mental health services, as we've seen in previous years. The reference to the MIS is what's been speculated in the press rather than any direct communication we've been in receipt of. And in West Yorkshire, over the past few years, we have maintained our commitment to investing through the Mental Health Investment Standard. And just as a reminder, mental health is one of our 10 ambitions for the whole of the population of West Yorkshire. Specifically, over the past 3 years, we have increased the proportion of resources to support mental health services over and above those minimum national requirements. So in 22-23, we spent 438 million. That rose to 481 in 23-24. And our forecast for the end of this year is 521 million. So we have seen that increase, but again, just to acknowledge, we know that demand continues to grow. So in terms of what we're doing in West Yorkshire, our places are already on with looking at what our priorities are for next year, along with our mental health partners, and what that means for West Yorkshire level priorities for 25-26. We do remain committed as a board to increasing our investment in these vital services. Once we've got the planning guidance, we'll be able to finalise our own plans, and of course they'll be published through the board meeting in due course.
Thank you, Sarah. And then we have a second question. Laura.
Thank you. Yes, our second question is from Dr John Puntis from Leeds Keeper NHS Public. The governance standards for the Integrated Care Board include a commitment to transparency, while the ICB website declares this partnership is yours, it belongs to us all. I note, however, that the medium-term financial plan, the financial forecast position and the external financial review by management consultants PricewaterhouseCoopers are reserved for the part of this meeting from which the public are excluded. I think this reinforces the perception by many that ICB boards do not in fact belong to us all and are neither transparent nor accountable. I understand the West Yorkshire ICB has a savings target of around £434 million. I would like to know if the current savings target was to be achieved, what would be the impact on numbers of clinical and non-clinical staff, and if such savings are calculated to drive an improvement in health and wellbeing for the people of West Yorkshire while reducing inequalities. And I'll pass to you, Cathy. Thank you.
Thank you, Laura. So I'll take the first part around management of items in board meetings in private and in public, and then I'll hand to my colleague Jonathan. So we do consider very carefully which items of business or decisions are best considered in the private session of our board meetings. These are by exception because, as you say, our commitment to transparency is something that is important to us. The only reason where we do so is where we consider that the public interest is better served by having those conversations in private in the first instance. We have a unique position in West Yorkshire NHS system that we consider in detail information that relates to the ICB as a statutory organisation, as well as the 10 NHS providers in West Yorkshire who are also statutory bodies. In certain circumstances, there is information which has not yet been publicly shared by those organisations, which is often related to timing rather than not making the information available. And it remains important for the ICB board to discuss these issues, even if this needs to happen in private initially. I can assure you that information on the financial plans of West Yorkshire ICS and its constituent organisations, as well as in the in-year financial positions, are reported fully through the public board meetings of the ICB. So, for example, for this board meeting in public, we have system financial reporting available in the Integrated Performance Dashboard under item 18, and that's available on our website as well. I'm going to hand over to Jonathan now for the second part. Thank you.
Okay, thank you. So thanks very much for the question raised about Our efficiency target, which as you said has a value of £434 million for the year, and the links to our workforce. Firstly, to put the value of £434 million into context, this equates to about 7.5% of our NHS system allocation in West Yorkshire of £5.6 billion. I should clarify that level of savings planned to be delivered from across the 10 provider organisations in West Yorkshire, as well as the West Yorkshire ICB as a statutory organisation. I should also note this level of saving, combined with the cost pressures and growth that we faced in 24-25, did not lead to the development of a balanced financial plan this year. Rather, our system or collective plans were such that we submitted a planned deficit of £50 million to NHS England at the start of the year, and that didn't meet our statutory duty to break even, as we've planned to spend more than our financial allocation. So as part of the planning process for 24-25, we developed service and operational plans, supported by workforce, performance and financial plans. It's also worthwhile noting that the overall savings target of £434 million is delivered in a number of different ways. And whilst the largest single element is around our pay bill, we also seek to ensure that we deliver efficiencies across our non-pay budgets through better procurement or reducing waste, for example, as well as ensuring that we secure value for money from non-NHS providers and contracts. It's also worthwhile noting there's been a big drive this year within West Yorkshire, as well as nationally, to reduce the reliance, use and rates paid for agency staff and to an extent bank staff. And this allows spend on our pay bill to be targeted towards substantive staff rather than temporary staff, which has also got significant quality and continuity benefits. In terms of the overall number of clinical and non-clinical staff across West Yorkshire in 24-25, the overall change is broadly flat. This isn't so far as the number of staff at the start of the year was 68,386 whole-time equivalents, and the planned number for the end of the year was 68,333, which was a small decrease of 59. Over that same period, the planned increase in clinical workforce was 1%, with a planned reduction in non-clinical staff of 4%. And I should also point out this is in the context of a significant increase in NHS staff since 1920, whereas as a result of the additional money that was provided during the pandemic, workforce overall in the NHS has grown from between 15 and 20%. So what drives our planning is deploying our resources, whether it's about people, buildings or money, in such a way that supports our integrated care strategy as a partnership and our joint forward plan. Within this, we are focused on ensuring that we use our limited resources to reduce health inequalities, manage unwarranted variations in care, and secure the wider societal benefits investing in care, as well as using our collective resources wisely. And this was the case in 24-25 and will continue to be the case as we plan for the future. And I hope this provides a sense of our approach to efficiencies and their place as part of our overall plans.
Thank you. So thank you to Heather and to John for those questions, and those questions and the answers will be outlined in full when the minutes of the meeting are shared at our next quarterly board meeting, which is on the 18th of March next year. And just a reminder, we always welcome questions from the public in relation to our agenda that day. As I said, our next board meeting will be on the 18th of March, and we'll be inviting questions from the public by the 17th of March. So thank you again. We now move on to our Focus On session, and we have the luxury of some time together, as we've done throughout this financial year so far, in looking at the Integrated Care Board's role in reducing health inequalities. It's one of the roles that we play in an integrated care system, but particularly we've been working with colleagues in public health on understanding what our role is as an Integrated Care Board, as a commissioner and a convener of a health and care partnership. I'm really grateful to Sarah Smith. I've said it before, Sarah, but I'll say it again. Thank you for taking the brief from me around 6 months ago to make this happen. I'm really grateful to you and other colleagues in public health for encouraging us to take a life course approach, which is what you are enabling us to do today in looking at ageing well. Colleagues, you remember when we met in September, we were looking at children and young people's health, particularly looking at asthma and also looking at children and young people's mental health. We looked last summer at supporting people with long-term conditions, particularly those out of work, which is very much aligned with the new work we've started as a trailblazer area, which you'll hear more about later in working with a combined authority. But we have Sarah and Colvin here today to talk to us about ageing well in West Yorkshire. I encourage everyone around the table to comment, share questions, but I'm really interested in how you're going to take this information back into your work in a provider, at a place or a programme board or forum, because it's here to be helpful to you. So Sarah and Colvin, welcome, and I'll hand over to you to give us some opening remarks.
Thank you, Cathy, and thank you everyone for having us again for these Focus On sessions, which we really welcome from a public health perspective. To have that opportunity to discuss inequalities, which are unfair and unjust differences that we see between different population groups across West Yorkshire. As Cathy mentioned, for this item, we're going to focus on ageing well and on our older adult population, which make up around 16% of the population of West Yorkshire. I'm going to take the paper as read, so we're just going to give some introductory remarks to leave time for discussion. I'll give a bit of an overview and then hand over to Sarah and Colvin, who will summarise their sections of the paper before we come on to the recommendations for the board. We've taken on some feedback from the previous sessions in that we're really trying to focus on some specific recommendations that are within the gift of the Integrated Care Board to look at in terms of reducing inequalities. So the over 65 population that we're looking at today make up 16.7% of the West Yorkshire population. And that proportion has been growing and continues to grow over the coming years. And 26% of that population are limited, they report being limited in terms of daily activities, but that experience of how people are limited between the population groups in our older adults varies by different characteristics. Notably, the over 65 age group, we have less diversity by ethnicity compared to other age groups in West Yorkshire. That's something that's useful to consider when we're thinking about inequalities. And whilst we discuss today the role of the Integrated Care Board, we want the board to acknowledge that this is nested within the wider determinants of health, so nested in a wider approach to ageing well and other things that impact on health outcomes of older adults. So things like housing, income poverty and social isolation all impact on an individual's ability to access health and care services and to age well. And that's reflected in some other work across our borough. So, for example, Calderdale, age-friendly borough, and the Leeds Director of Public Health report on ageing well, which was the focus of that report for this year. Today we're going to focus on two specific areas. So we're going to focus on antimicrobial resistance, particularly linked to urinary tract infections and dental infections. Again, as an area where we see inequalities, an area where we think we could work collectively to influence a change. And we're also going to focus on the older adults element of palliative and end-of-life care. But I think it'd be remiss of us not to mention a couple of the other areas that, again, are really within the gift of the Integrated Care Board, which we've got some great work happening locally on, particularly around frailty, where we see 10% of the ageing wells of the older cohort, 10% of over 65s are living with frailty and 50% of over 85. So that kind of acts as a backdrop to what we're discussing today. There's some great work happening to support our frail elderly population, notably the mass service in Bradford, a project in Calderdale working with one of the primary care networks that's been nationally recognised, and some work in Leeds that's happening, identify people at risk of falls using really local intelligence. And we want to kind of feed in this approach to frailty into some transformation priorities that we'll come on to in the recommendations. I think as well, the other area we wanted to just raise awareness of at the board as well is older people's mental health. Older people have greater risk factors for mental health and actually are less likely to access some of our talking therapies. So there's a potential inequality there as well, just for reference for the board. But as I've said today, we're going to focus on antimicrobial resistance and on end-of-life and palliative care. I'm just going to hand over to Sarah first, then Colvin, just to give a 1-minute summary of each of those areas before we come on to the recommendations. Sarah.
Thanks, Sarah. I won't go into the paper in detail again, but I hope it emphasises why tackling AMR in West Yorkshire is so important. It's a really complex issue. It affects many areas, but we know it worsens health inequalities and increases risk for vulnerable groups. Even before usual winter pressures, we've seen healthcare-associated infection rates rising, some to levels we've not seen in over a decade. In some of all our specialities, elderly medicine has the highest prevalence, certainly for infections like E. coli, bacteremia, C. difficile. But older patients with no recent medical intervention are also arriving at our A&Es with severe but preventable microbial disease. And this is, of course, multifactorial, but in some of our communities, missed recognition of that infection and often self-directed antibiotic use also compounds the AMR issue. Really quickly, just referring to the recommendations in our paper, we hope really to achieve your support with, firstly, that commitment to support education and training, ensuring healthcare providers and the community have up-to-date knowledge of infection prevention, infection recognition for themselves, but also responsible antibiotic use empowers better self-care and also enables safer and more effective healthcare delivery. For a real impact, we also need to provide caregivers with the time, tools and resources to meet essential patient needs, real going back to basics, oral hygiene, catheter care, hydration, and accurate diagnosis, hopefully closer to homes as well. We need to provide adequate PPE and sanitation, and equally critical to reducing infections, that it will prevent lengthy hospital stays and manage those costs. Without these basics, things like antimicrobial stewardship risk being ineffective, so we need to get these basics right. And finally, we really want to strengthen our partnerships and our coordination. So we know that the fragmented efforts widen gaps in care and worsen inequalities. So we ask you to support a unified AMR and infection prevention response plans with clear oversight through the Health and Protection Board. And this coordinated action across providers will address AMR, hopefully reduce inequalities and pave the way for a healthier future for older adults in West Yorkshire. Thank you.
Thank you. So from a palliative and end-of-life care perspective, information from our health needs assessment tells us the mortality rate in West Yorkshire is rising, with the region showing a worsening trend compared to the England average. People's place of death also varies by age, with hospitals still being the most common place of death, accounting for approximately 45% of deaths, closely followed by deaths at home. However, as age increases, fewer individuals die at home. In contrast, for those aged 85 and older, care homes account for 30% of deaths. And however, care homes and nursing home capacity has declined over recent years. And with a projected 47% increase in the population that's 65 and over by 2040, there is a concern there may not be sufficient capacity in care home and nursing home provision to meet demand in the future. From a health inequalities perspective, we found that individuals from IMD1, so the most deprived communities, experience higher rates of A&E attendance in the last year of life. And people of Asian and Asian British ethnicity, and those in the most deprived populations, had higher rates of A&E attendance in the last 90 days of life. Those populations who experience health inequalities and health inclusion groups often have the poorest palliative and end-of-life care experiences. Therefore, tackling health inequalities must remain a core priority when planning and delivering palliative end-of-life care provision in our system.
Thank you, Sarah and Colvin. So just take into account what we've heard and take into account the intelligence in the paper, and also take into account the sort of current financial climate and other factors within the Integrated Care Board. We've kind of made some recommendations based on what we think we can do within existing resources and how we think we can make more effective use of existing resources to support people who are disproportionately impacted by either antimicrobial resistance, outcomes related to end-of-life and palliative care, and frailty. So the first two recommendations in the pack are related to antimicrobial resistance. The first one is around ensuring we embed an approach to reducing inequalities into our health protection response to newly formed Health Protection Board, and ensuring that has a focus on the intelligence we've heard related to AMR. And the second is around endorsing that approach and embedding that training around antimicrobial stewardship within our workforce. The next two recommendations are related to our health needs assessment for end-of-life and palliative care. We want to improve our cultural competence approach to supporting people with end-of-life and palliative care needs, so ensuring that takes into account needs related to ethnicity or religion. And we want to ensure that we take into account the needs of inclusion health groups related to end-of-life and palliative care as well when providing services. And in order to do that, we want to also ensure we're giving support to the future allocation of hospice grant funding to take into account inequalities and endeavour to deliver a more equitable service. And then finally, through the role of the Transformation Subcommittee, we have a recommendation related to learning from the good practice examples we have across West Yorkshire related to frailty, and ensuring that those are embedded into the development of our urgent and emergency care blueprint and our integrated neighbourhood teams. So thank you, Cathy.
Thank you very much for that overview. It's really, really helpful. And as you know, colleagues, you've also got an intelligence pack that sits with that as well. So I hope that's helpful in taking the information. I will take board comments and questions in a moment. The other thing I wanted to point out to you is, which we have done for these focus on sessions, is then invite Healthwatch to bring a local citizen's viewpoint to this, which is our commitment since September 2022 to make sure that we bring in the local citizens' voice into our decision making. The other thing that you have as part of your pack today, board colleagues, is also a video link to hear a patient voice. And I think it's an incredibly powerful yet gentle story that Abdul tells us, Abdul from Hare Hills, who shared his story in October this year about his care and about how improving communication and having empathy shown and respect to his faith was really, really valued by him. And he says, it made me feel that it was going to be okay. And if you haven't seen that, and for people watching this board meeting or in person or online, I really encourage you to have a look at that film as well, because we're really grateful to Abdul for sharing his story. So I'm going to hand over to Hannah Davis, who represents Healthwatch across West Yorkshire, to share the Insight report, to bring that citizens' viewpoint. And then we'll go around the table and take comments and questions. And Fatima, I'll come to you first. Thank you.
Yeah, thanks, Cathy. And thanks to Abdul for sharing his experiences as well. And like Cathy said, I really encourage people to watch the video if they haven't watched it. And it will be a series of videos. Abdul's going to share his experience over the next 6 months. So I'd really encourage you to watch those. As Cathy's mentioned, for each of these focus on sessions, we go out to people across West Yorkshire to hear about their views and also build on insight that we've already got. And we do that in lots of different ways, particularly through our West Yorkshire Voice, which is the way that we link with communities around West Yorkshire working. And the question that we asked was, what helps older people stay healthy and well, and what gets in the way? And then we also asked to share what works well and what doesn't work for older people in health and care services. We did that through an online survey, but also, as I say, through outreach. And many thanks to our West Yorkshire partners who got involved with that. So Bradford Talking Media, Asher Neighbourhood Project in Leeds, Spectrum Community Health and Bellal Church in Wakefield, Upper Valley PCN in Calderdale, Brunswick HIV Support Group in Kirklees, and Out Together in Leeds. So many thanks to those partners who got involved, and there are testimonies at the back of the report around that. I think this report, hopefully people have had a chance to read it and look at the report. I think it hopefully will serve us really well in some of that really important work we've got going ahead around the 3 shifts, from treatment to prevention, acute, community and analogue to digital. There's some very clear messages from older people there around those 3 shifts. So it'd be great to see how this report is used in that work. In terms of the things that people have highlighted, those wider determinants that Sarah's already mentioned, people have talked about in terms of healthy living, organised community activities. People would like to see more affordable and age-appropriate fitness activity groups. The importance of being socially connected, that came out really strongly in the Director of Public Health reports that I mentioned before, that Victoria led on in Leeds. And again, if you haven't seen the video that Leeds has produced around that, really recommend watching that. The importance of public spaces, green, social and cultural spaces, the vital role of transport, how living with a long-term condition impacts upon people. Sarah's already referenced the mental health and well-being that people often experience, those increased risks as they get older, the impact of financial well-being, employment volunteering and having a sense of purpose, and housing. So those are sort of the wider determinants. But people then talk to us about what can health and care services do in terms of what would they like to health and care services to recognise. And the first point we sort of highlighted was around the role of unpaid carers. For many older people, having someone that provides unpaid care for them is an integral part of what keeps them well. As well as providing love, support and companionship, unpaid carers play a vital role for older people in providing practical help, advocacy and help to navigate the system. But as the Carers Leeds State of Caring report highlighted, in terms of carer experience, it can have serious impact on carers' health and well-being, as a negative impact on carers' own health and well-being needs. Too many carers feel they are not listened to, and they're more likely to experience poverty. The next thing that people talked to us about was around accessing health and care services. People wanted to stay well, so what was important to them was having access to regular health checks, vaccinations, visiting the GP when they needed to, follow-up support, specialist helplines for people with long-term conditions, real factors that help people stay well. And then underneath that, the challenge around, for some people, around accessing their GP. GPs play an absolute vital role in the health and well-being of older people. Then we went on to digital access and exclusion, and we got a lot of feedback around that, and that is a particular theme that it would be good to pick with Showcat about that, around digital exclusion for older people. Some people find it hard to book GP appointments. Some people find it difficult to access health info and order repeat prescriptions digitally. Older people can feel nervous or distrustful of technology. Might feel that digital services are something they don't need or want to use, prefer in person. A need to rely on others can lead to disempowerment. And many have a smartphone but don't necessarily use it for all the ways that actually might need it to access care in that way. And many people, older people, feeling like they're being left behind by services with the drive to online. People also talk to us about communication needs. A significant proportion of older people have hearing loss or some form of hearing loss, and the importance of health and care services understanding that in the delivery of care, the adherence to accessible information standards, waiting times for particular care for services such as dementia support and social care assessments, the vital role of compassion and coordination, two of those 3 C's that we talk about a lot. The cultural needs, and Sarah's talked about that, about the needs of cultural needs being understood and playing into services. And Abdul's video is a really good example of what can happen when that can get right. There's a bit in there around dementia as well, and a feeling that the support isn't there for people experiencing dementia. And then really highlights the important role of the third sector for older people in staying well, how health and care system thinks about older people in general, and death and dying, which Sarah has picked up. So there was a lot in there that people shared with us. Out of that, we've identified 5 recommendations in terms of people's experiences. And I'll just run through those quickly. Sorry, Kathy. Number 1, with the fast-paced move to digital, we must recognise that a large proportion of older people in West Yorkshire will experience digital exclusion and poorer access to services unless we make sure that non-digital options are always made available. Recognise that good transport and easily accessible local services are a key factor in older people keeping well, and there's a recommendation there with the West Yorkshire Combined Authority. Older age is a time that people can feel more lonely or socially isolated. We need to prioritise free and low-cost activities and inclusive spaces for older people to gather and socialise. The communication needs of older people should always be considered and acted on when designing, delivering and promoting services. This is really important in terms of that transformation, in terms of how we deliver services. Be curious about people's needs, both at an individual and system level, and with a focus on health inequalities. This should include people's access, cultural and health needs, as well as proactively listening to unpaid carers, who are often important advocates. And older people want to be treated with respect by health and care staff and involved in decisions about their care. So very much, I think, the messages from people was very much around, I think, key messages around how we want to deliver care in future, particularly around the transformation and particularly around digital as well.
Thank you, Hannah. Thank you to you and your colleagues at Health Watch. I know there's a lot of work that goes into these insight reports, and we're very grateful for them. And the patient story, Abdul's story, is important, but then I think the insight as well is incredibly helpful to sort of, as what we should be doing as board members, is triangulating it, bringing it together to get that full picture. And I hope it's helpful to our colleagues over here as well to take away. So I'm happy to take some comments and questions. We have the luxury of at least half an hour or more to have a discussion. So I have Fatima, James, Rachel and Richard. And I'm interested in your comments and reflections, as well as maybe what you can do to take this information away with colleagues. Fatima.
So, as you know, ladies, I'm a massive fan of this work, and particularly of the work that Gulvent does as an unpaid carer myself. One of the recommendations that wasn't formally in the paper but was in the slide deck was recognising unpaid carers as a social determinant, and I really think it should be. I think in the context of frailty, the proportionality of people that are older that have caring responsibilities and the impact that has on their ability to stay well and to work, I think it's crucial. Which leads me to my other recommendation, which is I think we need to encourage, as anchor institutions, the adoption of our working carers passport across all organisations, and I'll take away an action for that to be embedded in the Fair Work Charter work that we lead within the combined authority. I also wonder whether, in the context of supporting people to age well, whether we're really harnessing the unpaid carer workforce as well as we could be. So if you think about the fact that 1 in 3 of our NHS workforce, 1 in 5 of our public sector workforce are carers, how do we support them to really enhance the care that the health and care system is providing, particularly at the moment when we're so constrained with just what we're able to do? You can keep people at home in the community for anything if they've got the provision and the training and development to do so. So I really want to ambassador that as much as we could do, and maybe something in the people plan that we're hoping to develop about recognising carers as part of our workforce and a commitment to develop them to remain to do so. I think the other thing as well, Sarah, just on the AMR stuff, is really recognising that there are certain communities who still genuinely believe that antibiotics are the answer to everything. And they come into community pharmacies, I've seen them, or when we're having community conversations where they genuinely think there's some conspiracy about why we're denying people access to antibiotics. I do think the work we're doing with multi-faith organisations could support addressing some of those myths, and also developing community ambassadors in that space to provide information to genuinely help people understand why it's important for them not to have antibiotics, and about really supporting them with conversations about a good death as well. So my final ask is, can we be a system where we have conversations about a good death, what a good death looks like, and to have it at any time? Because one of the most important things people remember, apart from a death, is the birth bit, and that has so much more resource and investment to when someone dies, but that stays with you just as much as when someone is born.
Fatima, thank you so much. That's really helpful. I'm pleased that you've outlined things that you can do yourself in your joint role between the ICB and the Combined Authority, as well as areas of expertise and lived experience that you have as well. Thank you. So we'll be noting comments and we're noting actions as we go along. The next colleagues to comment, we have James, Rachel, Richard, Kim, Shaukat, Bev. If I've missed you off, please let Laura and I know. Robin and Majid, I think, has just put his hand up as well. Okay, so we're going to next go to James.
Thank you, Chair, and thank you, guys, for your report there, both Sarah's and Colvent, and also Health Watch. I suppose a couple of points I wanted to kind of bring up, really. And Fatima's touched a bit on it, but I'll come back to it in a second there. I suppose throughout the report, or specifically around AMR, there was a discussion about the Health Protection Board. I just thought for the board people to be aware of. So we now have a West Yorkshire Health Protection Board in which AMR will sit within there, and both Victoria, who's sitting next to me here, and myself are co-chairing that with medical and public health leadership across our system, recognising our places. A lot of this happens, but again, collectively, what can we do? And I do think, in terms as a board, what was asked in terms of this paper and the presentation was about that oversight with AMR, and particularly with that lens of health inequalities. And I do see that as an opportunity within that board to be able to address and look at that. So I think in terms of picking that up, we can, and I accept that there. I also wanted to highlight, in terms of the AMR work, the antimicrobial resistant work, also in terms of our link with research. and the important link we have as a system with research and AMR. And there's some good work that's been done across primary care to encourage and support the kind of improvement and quality improvement with antibiotic prescribing, particularly around UTIs. And so it's been a very successful campaign over the past few years to how we support primary care with highlighting rates of antibiotic use, but also solutions and approaches we take with the use of antibiotics there as well. So, and it just links research as well with our wider function as an ICB as well in terms of developing research across the system there. And then my final point really is around the kind of wider education, which picks up on Fatima points there as well, because I think there is the opportunity, and I think the challenge is in terms of how do we bring in some of the discussions about antibiotic use and when it's appropriate and not, and the role of antibiotics. And also in terms of the end-of-life care, in terms of having those conversations much earlier. I wondered in terms of, I do think it's about community champions that Fatima's talked about there, working with our communities, but I actually think it's about education and in the early stages of education and how we have those discussions within our schools and schooling as well there. So I think important that we pick up on that, because that is the wider benefit of working across the system there. So those are my 3 points, but thank you very much, guys, for the report.
James, thank you. Could I just, before we go on to other colleagues, there's something you've talked about at this board before is about learning from deaths and the work that you're doing across the system. There was a point from Fatima which you've reflected on about supporting people and families and carers at end-of-life care. Learning from deaths is also about celebrating good practice and good care, isn't it, as well as understanding when there's been issues. So I don't know if there's any reflections there. You talked about community ambassadors, but perhaps work we could do across the system on celebrating good care at end of life.
Yeah, and I think, again, in terms of asking for support in terms of next actions, we can look at where we can kind of highlight some of that. I can work with Colvent. We look at in terms of also through our mortality oversight group and bring it into that agenda there. And I think probably through, we take the learning from deaths through our quality committee as well there, so and quality group as well. So I think there are many avenues we can do, but I will kind of take that out of here today with Colvin.
Thank you. And Nadra, I know as our new Quality Committee Chair, that might be something of interest to you. Okay, thank you. We'll move on now. We've got Rachel, then Richard, then Kim. Rachel.
Hi, yeah, I also have 3 slightly extended points. So the first one was the work of Niche Leads, which is the Nurturing Innovation in Care Home Excellence. It's a partnership between care homes and academics, and they've recently launched a series of reports about oral care, because they recognise that from care workers that was one of the biggest things that they wanted support with in order to do better. But we recognise that that's probably about 12 care homes in Leeds, and we've got 442 care homes in West Yorkshire. We also have a significant number of home care staff who would also benefit from this kind of guided, supported mouth and oral care work. And there's something in that around actually how can we extend the workforce's ability to do that, because recognising that oral care and mouth care gets more difficult if your hand-eye coordination is poorer, manual dexterity, all of that kind of stuff. But actually it's very difficult to support somebody to manage their own mouth care, and that's actually very skilled and skillful work that our home care and home assistants are doing. So that's something that we could look at, maybe looking at expanding how we get that good practice spread further around. The second point I was thinking was in relation to the Mayor's Dementia Housing Task Force, which I've been sitting on. We've been recognising, working quite significantly, and we do think there are significant things that can be done in terms of home environment and the built environment. But actually what we're saying is that whilst we want to maximise independence in older age, what we also want to do is maximise connection. And that's something where we're recognising that as budgets are getting cut left, right and centre, it's actually we're doing better at keeping people in their own home, but then actually what we're doing is limiting people to their own home, and actually connection is incredibly important, not just for brain development, happiness and end of life, and that's really put in there. And then the third point was really about, you mentioned there that we've got a slightly smaller percentage of our over 65s who are white ethnicity. I would also recognise that there's a massive diversity within the white ethnicity, including Irish, traveller and others, but we're also just about to be on the cusp of that super diversity. So not just 2 or 3 dominant non-white identities, but the super diversity that we've had in the migration. And I'm not sure that we're quite prepared for that. And it gets incredibly important at end of life, as well as all of life. But I think that's something that also where we've got to plan our workforce and our workforce planning for that super diversity that we're about to experience.
Thank you, Rachel. There was something in Abdul's story as well about teaching the younger generation. That was one of his points about something could be improved upon. So I think that supports what you were saying there about improving and supporting the workforce for current and future care that will be needed for our population. We'll go over to Richard, then Kim, then Shaukat. Richard.
Thank you, and thank you again for the report. I think it's really helpful, really useful. Again, 3 points, if I may. There's been extension of the prescribing of antibiotics into the Pharmacy First scheme, and James alluded to the really useful reports that GPs receive on a regular basis about their own prescribing, their practices prescribing. I just wonder whether that is being provided to pharmacists as well, because I think it'd be really helpful for them to see, how their prescribing sort of matches with their peers and with the wider system. Because I think there is a whole issue, as Fatima and James have also alluded to, about education, not just professionals, but also patients as well, and the wider public about the best use of antibiotics and appropriate use of antibiotics. I was asked just a few hours ago, sort of by a patient when I was in surgery, sort of whether they had an infection or a virus. And I think just a simple example, of how sort of some basic misunderstandings, around infection, sort of, and what's appropriate for treatment. The second point is just to reflect that you mentioned the paper around the pressures of mental health services for older people. As a GP in Leeds just a few days ago, I received a message that Crews, the voluntary service in Leeds, have suspended referrals to their service for the time being, again because of system pressures and pressures that they're under. Just yet another sign of the pressure that mental health services right across the board are under. And that's a really valuable service and one that we should try our utmost to support. And linked to that, with the end-of-life care section of your report, again, which was excellent, I do worry about the capacity of our hospices. You mentioned the pressure on care home capacity. Have we done any analysis around hospice capacity, not least with the media reports that we've seen over the last few weeks, around real concerns about the funding model for hospices and the pressures that they're under, and actually they're cutting services sort of rather than potentially expanding them because they just don't have the resources to be able to support what they're currently doing, let alone what they might need to do in the future.
Richard, thank you very much. And I'm glad you've mentioned that. Rob and I were talking through that just yesterday in supporting our colleagues in the hospice movement. Could I just ask Sarah and Culvin, if you'd just answer Richard's question there about the work with pharmacy, and then we'll take the next round of comments.
Hi. So just to come in on a few of those things, I suppose from Pharmacy First point of view, the data's just starting to come into us in terms of being reported from Pharmacy First and how that looks. But at the moment, that's just prescribing data. And I think what you're talking about are the LAMP reports, the lowering antibiotics, which is a whole suite of resources of evidence base, of updated NICE guidance. So definitely we'll take that back. And I think as the data starts improving from Pharmacy First and that prescribing, that is when we'll be able to think about taking it through for LAMP. But one thing we are doing and one thing we're considering at the moment is to take out the target resources and GP training, the target resource training for antibiotic prescribing out to community pharmacy, because we've recognised that there's a gap in training provision for community pharmacy in that sense.
Thank you. And just to note in that point on hospices, we know that the hospice movement in the UK are calling government for a package of funding to avoid any further cuts, for them to recognise significant pressures and in the hospice movement at this time and recognise the good work that goes on in West Yorkshire. And I know there's some examples mentioned in the paper as well, particularly in Leeds. So I'm sure we will pick that up again, and going to go to Kim. So I don't know if you might comment on that as well, Kim, but over to you.
Thank you.
great paper, and I suppose my comment is less for you guys and more for us as a board to think about this in the context of our wider conversations around strategy and transformation, in, you know, given the ageing population and the widening health inequalities and the pressures that we're facing. So I'd love us to be a bit more ambitious in the recommendations of what the ask to the board is in terms of this work. You know, there's a reference in here to the hospices clearly, and I think that's been really clearly articulated that, you know, the hospices are playing an amazing and vital part of the jigsaw in terms of palliative and end-of-life care, but the opportunity to really look at health inequalities in this space can't be landed with the hospice grant because we don't pay much hospice grant in comparison to the money that's fundraised from the community. So I think the appetite from the hospices to do some real meaningful transformation in the space is very, very clear. Some of their opportunities to do that are limited by the model that hopefully will be nationally addressed. I think there's also we could all be looking more holistically about the connectivity between this and all of our programmes. So with my hat on Power of Communities, there's the hospices are part of the VCSE, but actually that conversation about connecting to the community around those important conversations around death and dying sit in those 14,000 organisations that are embedded really, really close to our communities. They don't sit really in the statutory services. So I think let's explore how we create some connectivity there. And also I would really love to have a recommendation here about how we're picking this up within different bits of programmes so that Colvin isn't just having to have this conversation in isolation in one programme, because this, you know, for the aforementioned reasons, this matters to us all, both in terms of transformation and sustainability. And it would be great to have some accountability around that. How are we going to measure this? How are we going to look at whether we're making some progress? Thank you.
Thank you, Kim. And I think you've helped me with one of the things to do in terms of all what will end up being 4 reports by March on the life course and the role of the ICB in reducing inequalities, is how each programme board and each provider collaborative in place take those documents and respond to them, so it isn't just an individual and it's not just siloed. Shaukat, then Bev, then Robin, Majid, Sarah, AC, and then Rob, come to you towards the end, if that's okay. So Shaukat.
Thank you, Kathy, and very, very good report, and thanks, Hannah, also. I just want to add a few comments with regards to the Health Watch report, and one of the recognizing fact is about the digital divide and digital inclusion, and these are part of our strategy on day-to-day findings, and with the use of the new emerging technologies, especially with the AI, so what the future looks like, that it would be a minimal engagement, especially on different segments of age groups, to make sure that they also benefit these digital tools without interacting or inserting too much of data through AI. So that's one part. And then the second part is about through digital data, and if we connect everything together, then that will also drive us and help us to identify those segments where non-digital solutions are important. So by using digital, we can also narrow down those segments in the society where then we can hit with non-digital the tools. Thank you.
Thank you, that's really helpful. So perhaps I'd encourage you to get together with Health Watch, as well as talking with our place accountable officers as well. Bev, then Robin, then Majid.
Thanks, Chair. So a couple of my points have already been covered, but thank you again for the paper. I think that to focus on ageing well is time well spent because of our ageing population, but also often we don't focus on elderly population, which is a shame, given 16% are over 65. I think that we could have separated quite a few of these into individual focus on sessions, but we are time poor. So I think that in terms of some of the asks and the recommendations, I'm massively supportive of the education of community providers. If we think about what we did in COVID around infection prevention, it worked incredibly well. So I think that, in terms of prescribing, but also IPC practice, absolutely in support of that. it's already been picked up by James and Fatima, but I think that in terms of the antibiotic prescribing, we need some massive public-facing comms around this, because people still think that is a panacea for everything. So it's been said, so I'll not continue on that. I think this is what I'm going to take away, Cathy. In terms of the request or recommendation around a West Yorkshire Unified Response AMR and IPC, myself and Sarah have had a couple of conversations. We've already started discussing with the place-based directors of nursing and quality teams of how we're going to operationalise this and report up to the Health Protection Board. So we will continue with what that looks like, and happy to report back if required. I think in terms of end of life, if there's one thing the assisted dying bill has done, is it's shone a light on palliative care and the need to improve this. And I think that we should have more talk, again, as has been mentioned, talk about dying and preferred place of death. We started having these conversations years ago when I was probably a staff nurse, so a lot of time ago, in a provider organisation, and I still don't think we've got it right. So massively supportive also around the recommendations of the cultural competence work. But what I would say is, in some of our providers, and whether they be voluntary sector or NHS providers, they're doing some amazing work around end of life and cultural competency, and I think it's how we share this across West Yorkshire. And then in terms of the frailty and inclusion in the development of the integrated neighbourhood teams, I think we've got to do that. We've absolutely got to focus on that, because then we can start to see significant change. I think what is worthy of further conversation are the recommendations around the provision of a dedicated palliative and end-of-life offer, because I'm not sure what that looks like, and also the allocation of grants to hospices. Thank you.
Bev, thank you very much. That's incredibly helpful. And you've talked about just that early part of your work about working with place directors of nursing, reporting into the Health Protection Board. I think that's something that, for information, our Quality Committee can also note as well on progress. And I'm pleased that you talked about the cultural competence as well. It's something that came through Abdul's story as well, about a clinician being culturally competent to then help enabled him to practice his faith, which is really, really powerful in that story. And thank you for sharing that. So we're continuing through the help of Amy to note comments and questions and actions and pledges that people are making around the table, which is incredibly helpful. We're going to go to Robin, then Majid, then Sarah, then AC.
Yeah, thank you. It's really good papers. Looking at the kind of paper that you've done, Sarah, and then the Health Watch paper, I just thought a sort of a bit of a challenge would be that there's quite a deficit model of the last years of life. And I guess I sort of thought about, it can be a point of joy, of opportunity, of happiness, of incredible kind of connection, can't it, where things kind of get into perspective. And I thought there's a lot of kind of strength-based opportunities in the material that Hannah's got about the Upper Valley, obviously I know well, and the way in which the connections of that community, their sense of attachment, belonging is really strong and very hyper-local, gentle, small, accidental moments that can be very important in people's well-being. So I wonder whether is there a chance to build more of a strength-based approach to this that sees the capacity of people and recognises that those strength-based moments require some very practical things like a bus that goes on time, or a cafe that's open, or a local shop, or a post office that kind of has a connection to people in their lives. So, and I know in Todmorden, Morrison Supermarket actually is a place where people go and connect. So I just wondered whether in the recommendations, and the role of faith communities is really strong in that as well, about giving a chance for people to experience sort of some sense of flourishing and joy in those older years, and particularly the final years of life. So I thought it was a bit of a challenge. There's some lovely anecdotes, aren't there, in the Health Watch report. And so it was a bit of a challenge back about, can we as a system not have to think about more services and more money, but just sort of nurturing and cultivating those things really in people's lives. Thank you.
Thank you, Robin. That's really, really helpful and complements what Hannah was sharing with us as well. We're going to go to Majid, then Sarah, and then AC. But colleagues over there, you have a challenge from Robin there to reflect on. Majid.
Yeah, thank you. Thank you for the report and the presentation. Really, really helpful, and also Hannah for the community insight. So 2 or 3 quick points. So first one, you acknowledge that we have to go back to basics in a number of these areas, and that sort of echoed through the Health Watch report. So when we talk about cultural proficiency, it'll be really, really good to broaden that. So where we've got people, for example, lip reading and masks, people not removing the mask, so as broad as possible in that space. The thing is, with the sort of Health Watch report, there's a number of recommendations there, and I don't think they've all fully translated in your recommendations. So I think another look at that would be really, really good and sort of fits into your broader back to basics piece, I think. The thing is, we talk a lot about inequalities, and in some cases they're getting worse. I think we should build in some aspiration, and I suppose that sort of links in a little bit to Robin's point. Where do we want to be? So we can hold ourselves to account that are we actually making progress, or are we going to do what Rob normally says is about keep admiring the problem. So I think it'd be good to see where possible or where practical we have some aspiration that this is where we want to be, and these are the actions that are going to help us to get there. Thank you.
Thank you, Majid. And that really aligns with what the Combined Authorities plans are about healthy and resilient places as well. So it very much complements local government view. We'll then go to Sarah, AC, Therese, and if there aren't any other comments, I wanted to ask Rob, I don't know, Victoria. Oh, we've got Lou and Victoria, we're building more people. Then we'll go to Rob, and then we'll come back to our colleagues over there. So Sarah, then AC.
Yeah, thank you. A great report. It's always a great report when you learn things new that you didn't know beforehand. So really appreciate it. And just to build on some of the comments that have been made, and the discussion here, it's reminded me the importance of not lumping people all in the same bracket. I remember, again, like Bev, when I was doing my nurse training, we were really instilled into us. You're talking about a big cohort of people spanning, a couple of decades. So a 20-year-old is very different to a 40-year-old, a 65-year-old is very different to an 85-year-old. And the report that the Director of Public Health did in Leeds talked about ageing well once you get past 50, so that broadens it even more and makes it all close to our own hearts in terms of what that means to be ageing well. Specifically on hospices, I think there's something about the reputation of hospices, because they're not associated, I don't believe, with people that are of older age. They are typically associated with people with cancer and other conditions that aren't associated with old age. So that's just something to think about as to whether, even amongst the professional sector as well as the public, how often is it seen as something that should be routinely available to people at older age. And again, I'd wonder whether the assisted dying bill will bring that more into the fore in terms of that universality of access. And the other bit that really struck me with some of the data about end of life and people presenting at A&E or different appointments, I don't know what's best. So, and again, it's this challenge, isn't it, of don't write people off and assume that, well, you're a certain age, therefore we're not going to provide interventions to save your life or treat your condition. Or do we send people to A&E too much when they should have an advanced treatment plan, and all of those choices? So it raises more questions than I suppose it answers, and I think it's important that in the neighbourhood model, that's the approach we should be taking, of knowing people that within this population and providing that person-centred, compassionate and joined-up care. And the area that's not specifically touched on, but just a reminder and reassurance to the board, specifically around dementia, is we do know at some point we will be required to provide the dementia-modifying treatments. That's not yet a decision that's been made by NHS England, even though they are available. And part of our conversation is we'd need to take a West Yorkshire approach to that. It will impact on primary care, it will impact on secondary care, diagnostics, it will impact on mental health services, the role of the VCS, and a huge amount of work involved. So that's something that I think we just need to keep included, that would be an area that we'd need to pick up at any point the decision gets made and the communication comes through that becomes available, because we know as soon as that happens, that, like we've seen with other new drug treatments, public demand is already there waiting at the gate. And then as soon as the media announces it's available, the demand starts straight away.
Sarah, that's really helpful. Thank you. And as part of the documentation you have, it's also particularly asking for our ICB West Yorkshire Transformation Committee to have oversight of best practice, but that also connects with the blueprints we're developing for the system and an urgent and emergency care and integrated neighbourhood teams, just to complement what Sarah was saying there. So then we're going to go to AC, Chair of our Transformation Committee, then Therese, Lou, Victoria, and then Rob.
Thanks, Kathy. Thanks for that report, really comprehensive. And I think it's close to my heart as well. Just applied for a MRC grant on AMR using community techniques, but something as an offer as well, which we can have a conversation outside of this in terms of translating that work into practice locally. But this is also a huge ambition for us. This is ambition 6 for us in terms of the system, and there are 4 or 5 metrics. So really it's good to see that coming through. If you look at the performance dashboard later on, you could see those trends manifesting gradually. So really appreciate the update and the deep dive on this. A question I was reflecting on, we are talking about health inequalities, and we are taking a lens on certain aspects of the work in terms of care. Here we are looking at AMR, end of life. It might be useful to step back and reflect which particular aspects of interventions are working well in a certain aspect of those interventions, which can be translated elsewhere. So as a system, as a whole, health inequalities approach, what's working well and what we should be focusing on next in terms of highlighting as key transformation priorities, acknowledging that there will be differences in approaches for various parts. So I think it's just sort of stepping back from that and getting a very reflective view in the next update. The second bit was around the digital bit, and I think Shaukat has covered it. Request would be is take us really strong, because given the digital developments and having worked with newer sort of technological approaches where you are having voice and conversations rather than interaction with devices, which eliminates the challenges of poorly designed systems to start with. With those coming on board, I think we have an opportunity to really take a considered approach across the diverse range of population that we have. And there are really good example case studies. Again, let's have a chat outside of this. But as part of the digital strategy, Shaukat has mentioned, and I'm glad to see that you'll incorporate some of those thinking so that we do harness and completely explore that opportunity before we go back to analog.
Thank you very much. And as I said, we've inviting a view on, and an update on our digital strategy across the system and our digital maturity as a system at our April board development session as well. I think that's really helpful insights also from UAC. Therese, Lou, then Victoria.
Thanks, Kathy. So just taking the challenge, I think, from Kim and others about the so what, just give you an example of some work we've done in our place, work that's starting actually, we probably could do with some help on it. So I, in a candid way, asked our team about population health and what does that actually mean, what can we do with it? And they went away and did a piece of work on palliative care, using the data and the population health principles. And to summarise, in our place, I think we have 0.7% of our population who we can identify as going through palliative care. We spend directly £5.7-ish million on direct services, but actually we consume about £112 million worth of care through ambulance transfers, A&E attendances, unplanned admissions. And this is a huge amount of work, so this is just a very brief summary. So the challenge that we've had the conversation about in our place is, so how do we do something differently to shift that dial? So do we look at the 112 million? Do we look at the 6 million, or do we look at something in the middle? Because I know, and we have GPs, for example, on our place partnership, that actually if you put a bit of additional resource into that general practice piece, or into our care homes, or into our palliative care teams, we could make a difference. So actually, my challenge was look at the 112, but I think we're going to look at the 6 and maybe shift it up a little bit. It's the start of a conversation. We then got lost in the how and the complexity of it, and I think what we need to do is commission differently, probably a lead provider commissioner model to actually look at the whole pathway for palliative care. And I think in terms of what the ICB board can do, you can hold us to account in places for taking that piece of work away and maybe looking at increasing from 6 million to 10 million rather than reducing from 112 million to, I don't know, 60 million, which is my challenge. But when we look at the financial issues that we've got in our place, those are really good examples of how if we look at whole pathways of care differently, how we can shift resources and actually do much better for our patients.
Thank you, Therese. I'll leave Rob to respond at the end on that, but it makes sense to me what you're suggesting. So thank you, and thanks for that update. Lou, then Victoria, and then we'll come to Rob.
So I enjoyed all of the report, but I got hooked onto the frailty part of it, particularly because of the lower super output area, looking at the geographies, and it really sort of connected for me because we've obviously done a lot of work on winter plans, and we're about to go into a planning season, which is the more broader plans, including plans with YAS colleagues, Yorkshire Ambulance Service, around conveyances, etc. So looking at this data now and thinking, well, are those lower super output areas that have, you know, sort of have shown more conveyance rates or whatever? I know that we do use that sort of data anyway, but I think probably going, we've got these plans now in place. How does this fit with that? We've got some more planning coming up. I know it will be incorporated into the blueprint work, but I think we've got a bit more here and now, about to go into a new planning round, that we should sort of think about that topic and some of the others that you've brought previously on health inequalities and the dissection that you've done. So thank you for that, and it's more of an offer of working a bit closely together.
Thank you, Lou. I'm pleased that you talked about frailty there as well. Victoria, and then Rob.
Thank you, Chair. 2 points, if I may. The first one picks up on Robin's comments earlier, and I guess just to reassure the board that on behalf of all 5 of Directors of Public Health across West Yorkshire, in the conversations leading up to the item today and in talking through the paper with Sarah and colleagues, we were very much thinking about the whole system and what happens where. So to support Robin's comments around that there is so much work happening at place locally around healthy ageing in a much more positive way. If people get a chance to read the report we did in Leeds this year, it's actually a really inspiring report because it reassures you that poor health in older age is not inevitable. There's lots we can do about staying well, and actually most older people live independent, healthy lives. So there's a lot of positives around this story. So I think we're always very wary of kind of going into a sort of a default position of talking about kind of very negative things and quite specific things around the issue of healthy ageing and older people's inequality. So I think there is something about being able to tell the story really well about different layers of our system and different parts that people play in the system, all the work that builds this up as a jigsaw of stuff, a lot of which is incredibly positive work like you suggest, Robin. And I know Sarah was keen for the item today to be the very specific work that the board plays a lead role in, which sits alongside all of that other work that's happening. So again, I'll let Sarah come in on that, but that was definitely the conversations we had about how it all joins up. And if I may, just one other point, if I can slip in, Sarah mentioned it before, but that whole thing about inequalities in healthy ageing, when we did the work in Leeds, what was incredibly stark and is a local priority for the local place, and there's a huge amount of work going on around how we can support people to stay well for longer, is that we know that if you live in the most deprived 10% neighbourhoods, the period at which you hit the poor health that is the beginning of the end of your life is less than 52 on average for our communities. So I know in Leeds that's kind of 1 in 4 people will hit that end of life period of poor care in those poorest communities below the age of 52. So, this whole approach to healthy ageing and starting that earlier, when we can start it as early as we like and go to kind of preconception, but there is something about actually getting in there. There's a huge amount of recommendations around prevention, the prevention activity we can do, as well as the positive stuff that Robin's mentioned. So, just a comment really to assure that, we can tell that story around the whole system, and there is a lot of that positive work going on. Thank you.
Thanks, Victoria, and thank you for your contribution to this piece of work as well. Rob, I'm going to hand over to you. What are your reflections?
Just a few reflections, really. So first, I'm glad Robin said what he did. I think I was always struck by the work that's done in organisations or like Creative Minds, who've got a really nice piece of work they do with one of the local creative organisations where they take they arrange for people to have photographs at the end of life about how they want to be remembered. You know, and they make some really interesting choices, which usually tend to be positive and joyous, not gloomy and difficult, which kind of reflects where they are. I think the second reflection I would have is there's a lot of conversation about quality at the moment, which is right. And last time I think there was a major conversation about quality with Lord Darcy, because he's also back, isn't he? We did have high quality care for all, and that I think was the first time we really started broaching the issues of a good death for people publicly and talking about what that might look like. And I think we're at that moment now, aren't we? People have talked about the assisted dying bill, making that in people's minds and understanding that we need to make sure that there's the right arrangements in place for that. And I'm also reminded that GPs do make a note of when they think people are in the last year of life. You know, that's on record. So we've got the infrastructure, I think, for us to think about this appropriately. And what this session's reminded us, I think, I was talking at an event recently, and they said, how do you keep a focus on health inequalities in a financially constrained context? And the answer is you look at the evidence, you look at the insight. Well, it's kind of, well, who's turning up? And, you know, Brendan often reminds us that he's got people in his hospital who shouldn't be there, often because of flow issues, but there are also people probably who shouldn't be there because they're having unnecessary tests or interventions which they're not had any benefit because we haven't done the advanced planning or we haven't done the work in the appropriate way. So it seems to me that this session has been incredibly helpful for us thinking about how do we keep the focus on inequalities, and by doing so tackle the issues that we've got that we were talking about earlier in terms of planning, waste, efficiency, good quality, safety, etc. Because if we don't, what you get is what Therese described. You know, you end up with £112 million worth of services being consumed by people who could probably get a better deal if we spent the money differently. And that leads me to what we're going to do. I think we should accept all of the recommendations because they seem well-founded to me. We might need to do some work on the operational elements, and Bev and others have offered to help with that. And in doing so, I think we should recognise that all of our places are focusing on population health management. It's one of the 5 functions of an ICB. That it's likely the planning guidance will ask us to focus on some specific populations, and it will include, I think, people who are older and people who live in deprived communities. And therefore, that population health management work, the UEC blueprints, the neighbourhood health service blueprints that we're developing, needs to be informed by this work because it's necessary. And therefore, our planning needs to be informed by this work so that we can do more with the money that we've got and not see this as something that's going to start next year. It starts now. Just 3 other quick points linked to that then. So I think that we must focus on the carers point, and we do focus on carers. We need to make sure we continue to do so. We need to focus on the skills. We talked a lot about skills, and I think the stuff around cultural competence, but also I think about communication, basics around IPC, we need to really get into, and I think again Bev and Kate can help with that. And then I think the final thing would be, I'm really pleased that the team started with what's our responsibility and what can we do in the context of a broader partnership. And this board needs to be very demanding of itself and our investments to make sure that we deliver the biggest impact that we can. And I think we should be demanding from our partners in the ICS and the Health and Care Partnership, because what we're hearing is, you know, it's the wider determinants work that we do with the ICS and the Health and Care Partnership, which should be strengthened given the white paper publication today or yesterday, should be strengthened so that we can think about housing, we can think about the environment, we can think about some of those other have you got something to do type issues that Robin described. And we might want to think about, following this meeting, when we report to Health and Care Partnership next time, what's the ask coming out of this that we say to them, we're going to do this, within the ICS, the broader partnership is doing a lot of work. We need to remind ourselves of that and make it a priority.
Rob, thank you very much. And that's something we can look ahead to our Health and Care Partnership Board, our Integrated Care Partnership meeting, which is in January. And we'll have then one in April that, Ian, perhaps we can then work with Sarah and colleagues on how we bring this report, the previous two, and looking ahead to the next one, we'll be looking at mothers and babies, which again links with our strategic plan to make that ask of the partnership as well. Sarah Smith, is there anything you want to share before we finish up this discussion? Has this been helpful?
Extremely helpful, thank you, Cathy. And I think just building on what Rob was saying around the nesting this within the wider system partners is just so important, and how we often, in that complex in this complex system in which we work, think about this from our improving population health function. I think I mentioned it last time, is we have a bit of a framework to really kind of bring that into action. So what do we do? What do we share? Who do we want to influence? And what actually do we need to be aware of to get the job done? I think I've heard quite a lot of things today that, in addition to the recommendations, we can build on. So there's some actions I think that we can do around unpaid carers and embedding that within the people plan in terms of the working carers passport. I think there's things we can do in terms of the Health Protection Board and our IPC governance to build on our approach to inequalities, and there's some things we can do in terms of our approach to pharmacy and reducing inequalities in antimicrobial prescribing. I think there's lots of things we can do in terms of sharing through the Quality Committee around what constitutes a good death, and sharing around approaches to cultural competence, and sharing around the care homes work you mentioned, Rachel, and Leeds, as well as the place-based approaches to taking a sort of population health management approach to urgent emergency care and end of life. I think influence, that piece we can take to partnership board in terms of the combined authority links to transport and Fair Work Charter. Fatima, we can work with you on that, and also the mayoral dementia housing task force work. And I think that's all nested in what we need to be aware of, and in terms of the national strategy and work on in this space, so particularly on the hospice funding, the white paper and the wider NHS plan. So we will collate all of that into sort of an action plan, as you said, Chair, that we will bring back and coordinate for April's meeting. So thank you. Thanks, everyone.
Thank you. So Sarah and Corvant, thank you for presenting today and putting the paper together. Victoria, for your support alongside other public health colleagues, Hannah and Health Watch as well, Abdul for sharing his story as well, and colleagues around the table. It's been a very practical, pragmatic discussion about what we can do in the short term as well as the medium to long term. I'm grateful to you. I am assuming, therefore, that you're supportive of the recommendations that have been outlined, but there's further development there, which I think we're all supportive of. And thank you so much. I said to Sarah Smith a couple of weeks ago, this is what happens when you make the chair of the board a public health fellow. I'm interested in tackling health inequalities, but that shows the power of our fellowship in making tackling inequalities everyone's business. So thank you, Sarah and colleagues. So that is the end of the first part of our board meeting in public. We're going to take a break now for about 5 minutes or so, and then we're going to come into the strategic and governance section of our board meeting. But thank you very much, everybody, for your contributions.